Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. In this week's episode, we'll be covering the highly anticipated trial updates in genitourinary cancers from ASCO GU 2026 and what they mean for clinical practice. To begin with Enrique Gallardo from Parc Taulí University Hospital in Barcelona, who discusses final overall survival results from the phase 3 trial of radium-223 with enzalutamide versus enzalutamide alone in patients with metastatic castration-resistant prostate cancer.
Well, the phase 3 trial demonstrated that the combination of enzalutamide plus radium-223 compared to enzalutamide alone demonstrated a statistically significant benefit in overall survival. No? This was a hazard ratio of 0.76 with a P below the significance prefix threshold, and the difference in survival was 5.6 months between arms, with 38.2 months for the combination arm. So the significance of this is that the combination of two survival benefit agents independently may improve the survival for our patients. No? This also was associated to an improvement in radiological progression-free survival and with a moderate, but I think very manageable toxicity profile. The combination slightly increased the grade 3 to 5 adverse events from 19 to 29%. And in overall, I think it could be a good chance for our patients.
He also comments on how we should interpret the data from the trial and future combination strategies in prostate cancer.
The point is that the study population does not exactly reflect the actual scenario, no? Because most patients had received ADT or ADT plus docetaxel in the hormone-sensitive setting. So this should be interpreted with a little bit caution. Said that, there are other examples of benefit, of overall survival benefit for combinations, for example, or progression-free survival benefit. For example, lutetium with ARPI, ARP inhibitors with ARPIs, and so on. No? So the point is that, in my view, if you can combine two drugs with complementary mechanisms of action with no significant higher toxicity, and you can demonstrate an overall survival benefit, you may consider this option. Of course, patients in the phase 3 trial received subsequent survival gain hormone therapies and other therapies, but even in this case, the combination seems to improve the benefit. So it's difficult to establish a fair sequence, but for example, in our case, for patients having received abiraterone or only docetaxel or only ADT, this combination in patients, specifically in patients with metastasis, with bone metastasis, should be a good opportunity.
Next, Jan-Jaap Mellema from the Netherlands Cancer Institute in Amsterdam describes results from the phase 2 INDIBLADE trial of induction ipilimumab plus nivolumab, followed by chemotherapy as a bladder-sparing strategy for muscle-invasive bladder cancer.
So the INDIBLADE trial is a phase 2 study in which we gave patients ipilimumab and nivolumab combination, followed by consolidative chemoradiotherapy in an effort to really broaden the population able to receive a bladder-sparing treatment. And the idea for this came from the previous trial that was conducted by our research group, which was the Nabucco trial, in which patients with very bulky stage 3 tumors were shown to have very, very high pathological complete response rates using this regimen. And this also translated into very promising progression-free survival, and this gave rise to the idea that we might be able to incorporate this into a bladder preservation setting. And we set as a primary endpoint for this study bladder-infected event-free survival at 2 years, for which we would have a target of 70%. And we met this primary endpoint at 2 years at 78%. And secondary endpoints of the study were overall survival, ctDNA analyses, and safety. And though a bit premature maybe, but overall survival was very encouraging at 96%. There were no new safety signals observed in the course of the study, and ctDNA analyses showed that it had a strong monitoring power with patients that would develop an event, either remained ctDNA positive or became ctDNA positive at the time of the event, and conversely that patients that were not experiencing an event either remained ctDNA negative from baseline throughout the study or became ctDNA negative at either the first or second response evaluations. And bladder-infected event-free survival analysis by ctDNA status post-immunotherapy showed that ctDNA negativity was highly associated with bladder-infected event-free survival.
Following on, Pooja Ghatalia from Fox Chase Cancer Center in Philadelphia discusses an integrated analysis from the RETAIN-1 and RETAIN-2 trials evaluating ctDNA to guide bladder preservation in patients with muscle-invasive bladder cancer.
We will be presenting the results of RETAIN-2, the primary endpoint results of RETAIN-2. RETAIN-2 is a single-arm phase 2 investigator-initiated clinical trial where patients receive neoadjuvant accelerated MVAC plus nivolumab. And following neoadjuvant therapy, patients received clinical staging, which included assessment of the bladder with cystoscopy, as well as cytology and CT scans. Patients also received neoadjuvant testing of their tumor tissue to look for mutations in specific biomarkers that have been shown to be predictive of response to chemotherapy. And after completing clinical staging based on the presence of residual tumor in the bladder, as well as the mutational status, patients either get active surveillance, which is where patients don't get their bladder out, but they continue to be monitored with cystoscopies and staging. And patients who have either not the mutation or who have residual disease in the bladder go on to receiving an intervention. So this is the general schema of this study. We are going to be presenting the final results, and RETAIN-2 met the primary endpoint of 2-year metastasis-free survival. And also, this is exploratory, but in comparison to RETAIN-1, which did not include the nivolumab component, it was just neoadjuvant MVAC, we found that lesser patients had local recurrence and lesser patients had metastases compared to RETAIN-1 in RETAIN-2. And also, higher percentage of patients were able to stay metastases-free with an intact, non-irradiated bladder in RETAIN-2 as compared to RETAIN-1. So those are the main results of the study itself. We had also embedded circulating tumor DNA in RETAIN-1 and RETAIN-2, and I'll be presenting the integrated analysis. So we have a complete data set of RETAIN-1 and RETAIN-2 trial patients where ctDNA was incorporated, mainly at baseline and post-neoadjuvant therapy. And some of the main findings are, number one, ctDNA is a very powerful prognostic indicator of metastases, especially at baseline as well as in the post-neoadjuvant therapy setting. Also, ctDNA positive patients did really poorly in terms of overall survival. The second key take home from the study is that ctDNA can also be integrated in bladder preservation strategies. So, for example, we saw that patients who were ctDNA positive who underwent cystectomy, they did quite poorly. But patients who were ctDNA negative who underwent cystectomy had outcomes that were very similar to patients who were ctDNA negative and went on to active surveillance, which is a provocative question that leads us to consider possibly considering ctDNA negativity in patients who we are possibly offering active surveillance to in combination with clinical staging, of course. Additionally, we saw that patients who were ctDNA positive who underwent cystectomy had really poor outcomes, and those are patients who we may want to consider some additional therapies for, as opposed to offering them radical cystectomy as an option. And finally, one of the important findings was that ctDNA is really predicting systemic recurrence, but is not a good predictor of residual disease in the bladder or local recurrence. So among the patients who underwent cystectomy, if you look at their neoadjuvant therapy ctDNA status, the positive predictive value was 90%. So positive ctDNA correlates with residual disease. But the negative predictive value of ctDNA alone was just 32%. So a lot of patients who had clinical macroscopic disease that was found at the time of cystectomy were ctDNA negative. And this is a limitation to bear in mind as we design future bladder preservation trials, where we may want to incorporate definitely clinical staging in terms of endoscopic assessment, but also maybe urinary biomarkers or other biomarkers that can help us better monitor local recurrence.
We also have Joaquim Bellmunt from the Dana-Farber Cancer Institute in Boston, who goes through an exploratory analysis from the IMvigor011 trial, evaluating circulating tumor DNA dynamics in patients with muscle-invasive bladder cancer.
Yeah, in fact, what I did present is an exploratory analysis of this trial. It was exploring the ctDNA dynamics. To remind, the IMvigor011 it was a prospective randomized trial that provided a survival signal, testing if ctDNA positivity is a signal that can make the patients benefit receiving adjuvant atezolizumab. So the trial was positive in patients that have ctDNA positivity when they were randomized to placebo. So IMvigor011 is a trial that after surgery, patients having cystectomy, if there were like signs of a still active pathology, they were monitored with the ctDNA. And patients that at the beginning became positive or later on in the follow-up became positive, those were randomized. And then patients that were negative, they consistently followed. And these patients are the ones that have not recurred and have not been included in the clinical trial. So what we did is that in these two populations, patients that were included in the trial that became positive in the beginning or became positive later on, we have been exploring the differences between this timing related to the outcome. And also one thing that is new that we have been exploring is the concentration of the ctDNA in different settings. What we did in this trial, the first things that were presented is a correlation between the concentration and the timing of the ctDNA positivity. What we see is that the majority of patients are having positivity of ctDNA in the first 6 months, and the concentration of ctDNA is high. Patients that ctDNA shows up later, those patients have very lower concentration of ctDNA. Then we did an analysis trying to correlate the ctDNA concentration and timing with the pathology. And in fact, we saw that higher pathological stages at surgery correlates with higher concentration and early positivity of ctDNA. But we saw interesting things like patients with T2. We see T2 usually is sometimes people is questioning if you need to give adjuvant therapy or not. But some patients with T2 disease, they have higher concentration of ctDNA, meaning that these patients need to be checked and monitored. And then what we did is also correlate the timing of ctDNA being positive with the outcome, disease survival and overall survival, and also the concentration was correlated with the outcome. We saw that the patients that the ctDNA becomes positive sooner in the very beginning, those have poor DFS. So these patients have higher concentration, they recur sooner, and they have poor outcome compared to the patients that the ctDNA becomes positive in the follow-up. The second thing is the concentration. We saw that the concentration impacts on the outcome. We set up like 3 different levels, patients that were negative, and those were doing pretty well, not recurring. But if you have a ctDNA positivity of less than 0.1 or in between 0.1 and 3 or more than 3, you see that the curves are completely different. Obviously, all these patients that have some level of ctDNA, they recur and then might need systemic therapy. And then obviously we analyze the impact of atezolizumab in these different subgroups. We analyze the overall survival, disease-free survival, depending on early versus late ctDNA or depending on the different levels of concentration. We saw that atezolizumab was benefiting all the populations. Patients with low, intermediate, high concentration, patients having ctDNA early show up versus late. So, and this has been telling us a bit of the natural history of ctDNA, because some of these analyses were done in patients that never received treatment, meaning it's a way that what this ctDNA is telling us. And then what we did is we moved the real kinetics of DNA to see what's the impact of atezolizumab on the kinetics. What we saw that in fact, depending on the baseline values of the ctDNA, there is a benefit on outcome and on disease-free survival when you give atezolizumab. Meaning patients that are receiving atezolizumab with a high ctDNA concentration, they do much better. And this is translating on overall survival and disease-free survival. In fact, the IMvigor011 is the only trial showing survival benefit when giving atezolizumab in patients post-surgery if they are ctDNA positive.
Finally, Aly-Khan Lalani from McMaster University in Hamilton, Canada, discusses the CITUS-SHRINK trial, the first randomized trial evaluating stereotactic body radiation therapy with ipilimumab and nivolumab versus immunotherapy alone in previously untreated metastatic renal cell carcinoma.
CITUS-SHRINK trial was designed back in 2019 in an era where we had come out of data from Carmina and Certime, which challenged the use of routine upfront cytoreductive nephrectomy in most IMDC intermediate and poor risk patients. So at the time, we designed a randomized phase 2 clinical trial evaluating the addition of stereotactic body radiation therapy, or SBRT, early as an upfront cytoreductive approach versus patients getting the standard of care immunotherapy. Yeah, so what we found is that, at the era this trial was conducted, there were, I would say, a very high-risk population in the sense of the size of the primary renal mass, good balance between IMDC intermediate and poor risk patients, and all the other standard features of a first-line trial. But there were more patients presenting with liver metastasis in the interventional arm, bony metastasis. And so that's certainly in a small randomized phase 2 can impact outcomes. Ultimately, we did not see the 1-year PFS rate of adding SBRT to nivolumab plus ipilimumab versus nivo and ipilimumab improved. But we did see some interesting findings by the IMDC risk groups, and most importantly, in those who responded in both arms, the ongoing responses were better in patients who got the SBRT intervention, which tells you something about the biology that we need to uncover. In terms of radiation administered, there was no really detriment to giving SBRT in patients getting nivolumab and ipilimumab, or vice versa. So the safety and delivery of both modalities was reasonable. And we kept a close eye, obviously, on kidney injury and other type of renal toxicity. But consistent with what we know about SBRT, there's actually very good renal preservation and safe way to deliver radiation to patients to preserve renal function. So all in all, I think we're going to have more follow-up of overall survival, quality of life. We have patients who had treatment beyond progression in the intervention arm. We had patients who got downstream nephrectomies in the intervention arm, and we have biomarker work looking at tissue, serial blood collections, and serial gut microbiome collections.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.